Chapter 18, Eating and Feeding Disorders. Addie, age 15, is brought to the school nurse after fainting during gym class. She is grossly underweight, wears baggy clothes, and has dry skin. She complains of feeling cold despite wearing 2 sweaters. As the nurse examines her perfunctorily, she notices that Addie's skin seems slightly yellow, and a gentle scrape of her skin shows signs of dehydration. For our clinical picture, you could be thinking anorexia nervosa, bulimia nervosa, or binge eating disorder. When comparing anorexia and bulimia, anorexia is not eating, whereas bulimia is binging and purging. For anorexia, this is weight loss not driven by a desire to appear feminine, has high levels of self-control, and a body weight significantly below for their age and height. Less likely to have been overweight, underweight can be severe, and less likely to abuse drugs and alcohol. Versus bulimia, this is a social concept of femininity that drives their behavior. Impulsive and emotionally unstable, they have weight fluctuation that remains relatively close to norms. More likely to have been overweight, a normal weight which is slightly overweight, and more likely to abuse drugs and alcohol. Anorexia nervosa is characterized by an intense fear of gaining weight and experiences significant differences in sensation of taste, appetite, and satiety, feeling full. These unique, unpleasant sensations help to perpetuate the disorder, leading to restriction and sometimes purging. For our first audience response question, what do we mean by the term purging when we talk about anorexia nervosa? That be A, vomiting, B, excessive exercise, C, using stimulants or thyroid medications, or D, all of the above. In this case, the answer is D, all of the above. Purging is a type of compensatory behavior. While most of us think of self-induced vomiting when we hear purging, it also refers to excessive exercise, the use of laxatives, enemas, diuretics, stimulants, or thyroid medication aimed at decreasing their weight. By the DSM-5 criteria, they're restricting energy intake to below requirements. There's a significant loss of weight and malnourishment, intense fear of weight gain or persistent interference with weight gain, a disturbance of body image, and a self-evaluation linked to body weight and shape. For the restricting type, during the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior. The binge eating purging type, during the last 3 months, the individual has engaged in recurrent episodes of binge eating and binge purging. The lifetime prevalence of 0.5% does not represent the actual prevalence. Fewer than half actually seek help for the condition, and individuals tend to conceal the symptoms. It commonly begins during adolescence or in young adults. There are many comorbidities that go along with this condition, such as bipolar disorder, anxiety disorders, depressive disorders, obsessive compulsive disorder, PTSD, and alcohol or substance abuse. As with many conditions in mental health, there is a lot of biological and environmental factors at play. For the biological factors, researchers have found genetic correlations between anorexia, major depressive disorder, anxiety disorder, OCD, and schizophrenia. They also found a correlation between anorexia and variations in glucose and lipid metabolism. For the cognitive factors, anorexia nervosa is an egocentric disorder. This is, individuals value their disorder. Although they don't know that their actions are potentially harmful, they believe that the benefits outweigh the harm. And for environmental, anorexia nervosa is associated with cultures that value thinness. The nursing process for anorexia nervosa. This is a subject I see come up a lot in both ATI and NCLEX. For our general perception, we want to assess the patient's perception of the problem, their eating habits, their history of dieting or purging, the methods used to achieve weight control, the value attached to a specific shape and weight, interpersonal and social functioning, and mental status and physiologic parameters. We also want to review the patient's perception of the problem, their vital signs, review their appearance, screen for suicide or self-harm behaviors, their nutritional and fluid intake, daily activities, and laboratory testings. During the assessment, Addie says, "This all started because my mom found out I fainted during gym class. It's ridiculous." She seems genuinely unaware that her low weight and other symptoms might be a source of alarm. Addie's skin is slightly yellow, and her skin has showed signs of dehydration. For our next audience response question, with that fainting spell in mind, to further assess for anorexia nervosa, the school nurse should ask, A, do you often wear heavy clothing in warm weather? B, when was your last menstrual period? C, do you use any drugs or alcohol? Or D, do you ever lose lapses of time? And the answer here is going to be B, as amenorrhea often accompanies anorexia nervosa. What is the yellow skin and anorexia nervosa linked to? Would that be A, lanugo, B, amenorrhea, C, the use of street drugs, or D, hyperkeratinemia? And that answer here is D, hyperkeratinemia. As anorexia nervosa progresses, the patient develops, among other things, hyperkeratinemia, which manifests as yellow skin. Lanugo, that fine body hair, and amenorrhea are other signs of anorexia due to other causes, including starvation and low weight. There are many nursing diagnoses that could go along with this condition, everything from impaired nutritional status, impaired cardiac output, electrolyte and fluid imbalances, disturbed body image, ineffective coping, chronic low self-esteem, and powerlessness. For our outcomes, we want to work to improve the patient's nutritional intake, monitor their cardiac output, electrolyte balance, and fluid balance. We also want to encourage a more positive body image with effective coping skills and improved self-esteem. We also want to plan to prevent refeeding syndrome. This is a condition that occurs when nutrients are restored. Insulin stimulates glycogen, fat, and protein synthesis, in a process that requires minerals such as phosphate and magnesium. In severely malnourished patients, a refeeding syndrome may occur. This potentially lethal complication may result in fluid balance abnormalities, abnormal glucose metabolism, hypophosphatemia, hypomagnesemia, and hypokalemia. Thiamine deficiency can also occur. Reintroduction of nutrients are given slowly to help avoid this. Addie's condition worsens and she collapses at home. She's admitted to your unit with anorexia nervosa. You've completed your physical and biopsychosocial assessment of her. Which common personality trait is likely to present a particular challenge? Would that be A, lack of hygiene and cleanliness, B, lack of interest in self and others, C, irresistible desire to purge, or D, perfectionism? In this case, the answer is D, perfectionism. The common personality traits of these patients, perfectionism, obsessive thoughts, and actions relating to food, intense feelings of shame, people-pleasing, and the need to have complete control over their therapy, pose additional challenges. Our top priority is going to be monitoring for suicidal ideations. We're also going to focus on psychosocial interventions, along with pharmacotherapy and medical interventions. We also want to work to improve her nutrition, make sure she's attending psychotherapy, and being provided the health teaching and health promotion she needs related to this condition. Each patient is going to be unique. While research does not support the use of pharmacological agents to treat the core symptoms, consequently, psychotropic medications may be utilized for other comorbidities. They also may think of integrative medicine such as yoga, massage, acupuncture, or bright light therapy, in addition to cognitive behavioral therapy and other psychological therapies. Next would be bulimia nervosa. To meet the DSM-5 criteria, the patient must have recurrent episodes of binge eating, followed by recurrent inappropriate compensatory behavior. Both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight, and disturbance does not occur exclusively during episodes of anorexia nervosa. The 12-month prevalence for bulimia nervosa among young women is 1 to 1.5%, while the lifetime incidence of bulimia nervosa for women is 2.3%, and the lifetime incidence for men is 0.5%. Bulimia commonly begins in later adolescence, when the prevalence peaks into young adulthood. The onset of bulimia nervosa is rare in children younger than 12 and adults older than 40. It also would have significant comorbidities with depressive disorders, anxiety disorders, bipolar disorder, alcohol and substance use disorders, PTSD, and borderline personality disorder. The risk factors include genetics, which account for about 60% of the condition, along with cognitive factors, attachment challenges, and a self-evaluation based on weight and shape. There are also environmental factors, such as an internalization of a thin body ideal and bullying. The nursing process for bulimia nervosa. For our nursing assessment, we should include the patient's perception of the illness, their vital signs, system review, and appearance, along with a psychosocial history, their nutritional and fluid intake, daily activities, and other laboratory testing. Our nursing diagnoses could include things like impaired cardiac output, electrolyte imbalances, disturbed body image, risk for difficulty coping, risk for powerlessness, low self esteem, and risk for social isolation. For our outcomes, the electrolytes imbalance, improved cardiac output, and improved coping, positive self esteem, having the patient verbalize confidence and make informed life decisions. During the inpatient care, we want to interrupt destructive cycles, normalize eating habits, provide therapy for underlying causes, treatment for comorbidities, as well as counseling, health teaching, and health promotion. For our pharmacotherapy, Prozac, an SSRI, is the only FDA-approved medication for the treatment of bulimia nervosa in adult patients. This drug can be helpful for people with bulimia even in the absence of depressive symptoms. This would be in addition to our classic cognitive behavioral therapy and other therapies. Binge eating disorder. To meet the DSM-5 criteria, there needs to be recurrent episodes of binge eating. This is eating in a discrete period of time within any 2 hour period, an amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances. There would also be a sense of a lack of self control over eating during the episode, such as a feeling that one cannot stop eating or control what or how much one is eating. Marked distress over binge eating occurs at least one time a week for 3 months and is not associated with other disorders. These episodes are associated with three or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty afterwards. There are many comorbidities that could go along with binge eating, such as specific phobias, social phobias, post traumatic stress disorder, and alcohol and substance abuse. The 12-month prevalence of binge eating disorder for U.S. adults is 1.6% in females and 0.8% in males. For women, the lifetime incidence of binge eating disorder is 3.6%, and the lifetime incidence for men is 2.1%. The presence of binge eating disorder is higher in overweight populations, 3%, than in the general population of 2%. There are going to be many genetic, neurobiological, cognitive, and environmental factors that go along with binge eating. Those environmental factors include a social pressure to be thin, which are typically influenced through media, can trigger emotional eating. Social weight stigma, which is stereotyping or discriminating based on a person's body, is common in the US and perpetuates the cycle of binging. Other factors include a history of trauma, particularly emotional neglect, and a history of food insecurity, which is the result of not having reliable access to a sufficient quality of nutritious and affordable food. The nursing process for a binge eating disorder. We want to again assess the patient's perception, their vital signs, systems reviews, and appearance, their psychosocial history, nutritional patterns, and a history of weight cycling. Our nursing diagnoses would include impaired high nutritional intake, more than body requirements, disturbed body image, risk for difficulty with coping, anxiety, low self esteem, risk for powerlessness, or risk for social isolation. Our planning should include a balanced intake and a healthy movement. Implementation would involve avoiding judgmental language. Binge eating is not about food, but about coping with emotions. Help the patient track what events trigger an episode, and help them explore community activities or support groups. Use an incremental approach in goal setting, and make sure to include health teaching and health promotion about the dangers of the condition. While pharmacotherapy may seem to help in the short term, patients regain significant weight after stopping their medication. Some evidence has been found to support serotonin norepinephrine reuptake inhibitors, SNRIs, including Cymbalta or Effexor, in the treatment of patients with comorbid binge eating disorder and major depressive disorder. Other medications that are under investigation include tricyclic antidepressants and anti-epileptic agents. They may even consider bariatric surgeries in addition to cognitive behavioral therapy in extreme cases. Other feeding disorders would include pica. This is eating non-food items well past toddlerhood and is not part of another illness. In some cases of pregnancy, you'll see females eating things that are not food, stemming from an underlying nutritional deficit. I believe there was also used to be a TV show of people eating a lot of non-food items. Another feeding disorder would be rumination. This is regurgitation with rechewing, reswallowing, or spitting, and no medical or mental reason to account for it. Another feeding disorder would be avoidant restrictive food intake. In this case, it starts in childhood, with 40% of picky eaters resolving this condition on their own. They're usually characterized by a low BMI and no distorted body image. About 5% to 20% of children without other disorders may have feeding disorders. Prematurity, failure to thrive, autism, and genetic syndromes result in ranges of 40% to 80% with feeding disorders. There are no unifying etiologies for food refusal, but personal anxiety and family anxiety seem to be risk factors. Audience response question. Hypoalbuminemia in a patient with an eating disorder will produce which assessment finding? Would that be A, lanugo, B, jaundice, C, amenorrhea, or D, peripheral edema? In that case, this answer is D. Peripheral edema often results from that deficit of the protein albumin. And last slide. Mr. Anderson, a patient living at home with dementia, is found to be eating laundry powder detergent on more than one occasion. This is most likely a sign of which feeding problem? A, binge eating, D, rumination, C, bulimia, or D, pica? And that answer is D, pica. And it's a feeding problem as opposed to an eating disorder. It involves the eating of non-food items after maturing past toddlerhood. It's not part of any other mental illness. It's, unfortunately, they have a drive, an urge, a craving for something that is not food. But anyway, that's all we've got for this chapter. I'll see you in the next slides.